Good morning, dear colleagues. My name is Mina Sami. I am a lecturer of cardiology at Cairo University and at the Armed Forces College of Medicine. This is the first lecture of a series of lectures for the undergraduates in the internal medicine for the cardiology part. Today we are going to talk about Introduction to Ischemic Heart Disease for undergraduates. Covering ischemic heart disease will be on 3 small lectures. The first lecture today, Introduction to Coronary Artery Disease, we will talk about the anatomy and the pathogenesis of ischemic heart disease. In the second lecture, we will talk about the stable coronary artery disease. And in the third lecture, we will talk about the acute coronary syndromes. To start with the coronary anatomy, as we see, the coronaries are the first vessels to arise from the aorta just after coming from the heart. We have a left coronary system and we have a right coronary system. The coronary vessels move over the heart from the outside, not within the muscles and not from the inside. So they move over the heart from the outside and they look like a crown. And the crown in Latin means coronal, so they are named coronary arteries. To start with, the first vessel, the first coronary is the left coronary vessel or the left coronary system. The vessel that arises from the aorta is named as the left main artery. The left main artery, it arises from the upper portion of the left aortic sinus. And what is this? If we look at the aortic valve, we will have 3 cusps with 3 sinuses named after the coronaries. The one that gives the left coronary is named the left coronary cusp. The one that gives the right coronary artery is named the right coronary cusp. And the one that is not related to any coronaries is named as the non-coronary cusp. So our first vessel, the left main artery, arises from the upper portion of the left aortic sinus. So it arises from the left in relation to the left coronary cusp. The length of the left main is usually from 0 to 10 millimeter. 0 means it might be absent, but this is rare. And if the left main is not present and is absent, this means that the 2 main branches of the left main, the left anterior descending and the left circumflex, will come from the aorta from separate ostia. So this is a cut section of the aorta with the 3 cusps. The left main comes from the left aortic sinus, whereas the right coronary comes from the right coronary sinus. This is again the same topic. The left main coming from the aorta. As we see, the left main is a bit higher in origin from the right coronary artery. This is not important at the undergraduate level, but it is important for the postgraduate cardiology residents for the cannulation of the aorta while performing coronary angiography. The left main, after it comes from the aorta, it gives its 2 main branches, the LAD, the left anterior descending, and the LCX, the left circumflex vessel. This is the LAD, and this is the circumflex. Sometimes the left main gives a 3rd branch, so it trifurcates instead of bifurcating. It gives the LAD and the LCX, and in between the 2 vessels, sometimes it gives a 3rd vessel in this part named as the ramus intermedius. The LAD that we are talking about now, this is the heart, this is the aorta, this is the right atrium, and this is the left atrium. We know the right atrium from the superior vena cava, and we know the left atrium from the pulmonary veins. So this is left side of the patient, and this is right side of the patient. the left main comes from the left coronary sinus. It gives the left anterior descending artery and the left circumflex. The left anterior descending artery, it runs in the anterior interventricular groove. If this is the left ventricle and this is the right ventricle, the LAD runs in this groove. As the LAD moves in the interventricular grooves, it gives two types of branches. It gives diagonal branches that goes and supplies the lateral wall of the left ventricle, and it gives septal perforator that perforate through the septum that it's moving over and supply the septum. So the LAD runs in the interventricular groove and in most cases reaches the apex as shown here. LAD gives diagonal branches and septal perforators. The diagonals are those that goes to the lateral wall like this one. And septal perforator are the small ones that go into the septum. The LAD and its branches supplies the anterolateral wall of the left ventricle, the apex of the left ventricle, the interventricular septum, and the anterolateral papillary muscle. The LAD supplies around 45 to 55 of the left ventricular myocardium, and this is why when we have an acute coronary syndrome and a thrombus occluding the LAD, we call this vessel the widow maker from its dangerous consequences, as it supplies in some patients more than 55% of the left ventricle. So this is another demonstration. This is the aorta. This is the right side of the patient. This is the left side of the patient. He has a left main. The left main then bifurcates in this case into left circumflex and left anterior descending. Left anterior descending gives first diagonal branch and then continues its journey and gives a second diagonal branch, and it continues till the apex. All through it gives septal perforators to the septum. After the LAD, let's talk about the second branch of the left main, which is the left circumflex artery. The left circumflex artery is the second branch of the left main. If we go back to our image, this is the left main and this is the LAD going into the interventricular septum and interventricular groove, and the circumflex that turns, as we see, to the left. This is the left, and backwards, going to the AV groove. What is the AV groove? Is the groove between the atria and the ventricles. This is the left atrium, this is the right atrium, this is the right ventricle, this is the left ventricle. So this is the AV groove that continues on the back of the heart. The branch that the circumflex gives is named as the obtuse marginal. And then it runs posteriorly to the left in the AV groove, the atrioventricular groove. This is left main, circumflex going to the left and backwards. This is the back of the heart. Again, how we know this is the left atrium. These are the four pulmonary veins, so I know this is the left atrium, and these are the superior inferior vena cava, so this is the right atrium. And this is the left side of the patient, and this is the right side of the patient. The circumflex comes from the left main and goes backward and to the left. This is the circumflex. It's the circumflex going through the AV groove like this. If the circumflex gives this branch, which is called the posterior descending artery, so we call it a left-sided dominance. If the right coronary coming from the opposite side gave the PDA, or the posterior descending artery, we call it right coronary dominance. What is the posterior descending artery? It is the artery that runs in the posterior interventricular septum. In other words, it is the opposite of the LAD. It is the posterior descending artery. It comes from the right coronary artery in most cases. In 85% of the cases, the PDA comes from the right coronary artery. and in only 15% it comes from the circumflex. So the circumflex is the second branch of the left main. As it originates, it goes backward and to the left to run in the left part of the atrioventricular groove. If it gave the posterior descending artery, which happens in only 15% of the cases, we call it left system dominance. And if the posterior descending artery originates from the right coronary artery, as usual, we call it right coronary dominance. The final part I want to talk about in relation to the circumflex, the point of meeting of the AV groove with the interventricular groove. This is the atrioventricular groove, and this is the interventricular groove, is called the crux. So if the circumflex is dominant, in other words, it gave the PDA, which happens in 15% of the cases, then the left circumflex supplies around 40 to 50% of the LV. But if it did not give the PDA, so it is not dominant, it supplies only 15 to 25% of the left ventricle. PDA, as I mentioned, posterior descending artery, comes from the right coronary artery in 85% and from the circumflex in 15%. There is an important branch known as the sinoatrial node artery. It comes from the LCX in 40% of the cases. This is a still image of the cardiac catheterization. In cardiac catheterization, we go either from the femoral artery or from the radial artery. In this case, we go from the we are going from the femoral artery. If we see this black lumen, this is the catheter. It's coming from below, from the femoral artery, going into the descending aorta, coming up into the descending aorta, up in the descending aorta. In the part that is not in the image, the catheter goes into the aortic arch, then rotates and goes down in the ascending aorta, going down in the ascending aorta. So this is the ascending aorta, and this is the heart giving the aorta, and the coronary arising just above the heart, the first branch from the aorta. So this is our catheter coming from the descending through the arch, through the ascending aorta, and we inject dye. These are the coronary vessels. This is the left main artery. This is the circumflex going into the AV groove and to the left. And this is the LAD. This is another image showing the LAD. This is the catheter. This is the LAD. What we see here, these are the septal perforators going into the septum. And what goes to the lateral wall of the heart is the diagonal branches. So what about the right coronary artery? The right coronary artery, it arises from the right coronary cusp of the aortic sinus, as we mentioned, at a lower level than the left main. So left coronary cusp, right coronary cusp, this is the right coronary sinus, this is the right coronary artery, lower than the left main. As we see, the right coronary is lower than the left main. The right coronary comes from the right coronary cusp, goes to the right and backward in the atrioventricular groove. And as it rotates, this is the right of the patient, as it rotates from the posterior, it gives here the right ventricular branch, and then in 85% of the cases, it gives the posterior descending artery that goes into the posterior interventricular septum. And this is the catheterization of the right coronary artery. Again, this is from the femoral artery. We see our catheter coming from downwards from the aorta, and then it rotates in the part that we don't see in the aortic arch, and then it comes downward in the ascending aorta, and it gives the right coronary artery. The right coronary artery gives a very important branch. It gives the sinus node artery in 60% of the cases, the LCX in 40%. It gives the RV branches. So the right coronary artery is the one that supplies the right ventricle. and it gives the posterior descending artery in 85% of the cases. The right coronary supplies 25 to 35% of the left ventricle. So this concludes our first part of the lecture, which is about the anatomy, coronary anatomy. We have left main bifurcating or sometimes trifurcating into LAD and LCX, sometimes the ramus intermedius. The LAD runs in the anterior interventricular septum. It gives diagonal branches and septal perforators. Then the LCX that goes backward and to the left in the left AV groove. In 15%, it gives the PDA. It gives obtuse marginal branches, while the right coronary comes from the right coronary cusp or right coronary sinus, and it goes into the right atrioventricular groove, backward and to the right, and then ends by giving the PDA. It gives an important branch with the right, which is the right ventricle. These are important data to notice. So when we talk about the acute coronary syndrome, which vessel cause which type of ST elevation myocardial infarction, we will notice according to the anatomy. Let's talk about the pathogenesis of the coronary artery disease. Both stable coronary artery disease and acute coronary syndrome share the initial pathogenesis, which is the formation of atherosclerotic plaque. So both diseases start with atherosclerosis that causes an atherosclerotic plaque. So this is an image of the healthy blood vessel or healthy coronary wall. It consists of endothelium, which is the endothelial layer, and the muscle layer, the media, which respond to vasoconstriction and vasodilatation, and the outer layer, the adventitia. When our patients are exposed to factors that cause what we say as chronic endothelial injury, these factors include the risk factors for coronary artery disease, the hyperlipidemia, the hypertension, the smoking, the elevated homocysteine, the toxins, the viruses, the immune reactions. All these factors cause chronic endothelial injury. When there is chronic endothelial injury, the second step is endothelial dysfunction, which leads to increased permeability and leukocyte adhesion. The third step is that the smooth muscles start to migrate from the media into the intima, which is the layer separating the endothelium from the media, which cause macrophage activation. The macrophages and the smooth muscle cells engulf the lipids and start to do what we call as the foam cells, and starts to appear what we call a fatty streak. So after this process, we develop the atheroma. In this case, it is a fibrofatty atheroma. So the result of atherosclerosis is an atherosclerotic plaque, and this atherosclerotic plaque, as we see in this image, cause narrowing of the blood flow in the coronary vessels. So what happens in stable coronary artery disease? In stable coronary artery disease, the plaque is of the stable type, and we will know shortly what is a stable plaque. This plaque, atherosclerotic plaque, keeps growing and growing, and when the narrowing of the coronary lumen reaches 70% or more, the patients start to complain of symptoms. The 70% or more stenosis usually does not cause symptoms, which is chest pain at rest. Why this? Because the 30% or less lumen diameter gives adequate myocardial supply. يعني 30% المفتوحين بيبقوا مكفيين العيان في الوقت ده. ولكن when the patient exercise or goes through any kind of emotional stress, the heart rate increase. So the myocardial oxygen demand increase. So the 30% that was enough at rest is no longer enough. and ischemia starts to occur, and the patient suffers from chest pain. So, in stable coronary artery disease, the usual symptom is typical chest pain that we will discuss in the next lecture that occur on emotional or physical stress, anything that increase the heart rate and increase the myocardial oxygen demand. That improves when the patient rests or lie down to rest. So I mentioned in stable coronary artery disease that the plaque is stable. So what is meant by a stable plaque and what is an unstable or vulnerable plaque? We have three types of atherosclerotic plaques. We have one that is predominantly fibrous, made of fibrous tissue, and we call it the fibrotic plaque. And we have a calcific plaque. This is calcium in the vessel wall, and this is a calcific plaque. And we have plaque that is made of lipid pool, and this is a lipid plaque. So we have a fibrotic, a calcific, or a lipidic plaque. Or we can have a mixture of any, for example, a fibrocalcific or a lipidocalcific, or mixture of the three, or any mixture that can make sense. These are images that we take from a catheter that can image the inside of the vessel. So this is a real patient, a living patient. We have a catheter known as the OCT, optical coherence tomography. You can think about it as it is a camera that goes inside the vessel wall and uses infrared light to image the coronaries. If you look at this part, these are the three layers of the healthy vessel. This is the intima or the endothelium. The darker part is the media, and the outside is the adventitia. This is the normal part at this site, but this is a fibrous plaque that is bright. The well demarcation is the calcific plaque, and the one that we cannot delineate is the lipidic plaque. We can compare these images to this. This is a fibrotic plaque. This is actually pathology, and this is the fibrotic plaque. This is calcium, and this is calcific plaque. And this is lipid, and this is a lipidic plaque. So what is the vulnerable plaque or the unstable plaque? The unstable plaque is made of lipid. The fibrous and the calcific plaques are usually stable. However, the lipid is the unstable one. And it has what we call a thin fibrous cap that is liable to rupture or erodes, as we see. So this is an OCT image taken from a living patient for a vulnerable or unstable plaque. You can appreciate this is the healthy vessel, the three layers, the intima, the media, the adventitia, and this is a lipid plaque with a thin fibrous cap. This is a vulnerable plaque. So, what happens in acute coronary syndrome? In acute coronary syndrome, it starts with a vulnerable plaque, an unstable one, the one that is made of lipid and thin fibrous cap. This thin fibrous cap either ruptures, it ruptures, or it erodes. So we have either plaque rupture or plaque erosion. When the plaque ruptures or erodes, this exposes the subendothelium to the von Willebrand factor and the coagulation cascade and leads to activation of thrombosis. If the thrombus occludes the vessel completely, we will develop what we know as ST elevation myocardial infarction. If the thrombus does not obstruct the coronary completely, this is what we will call a non-ST elevation acute coronary syndrome. And this is a diagrammatic illustration for a plaque rupture and erosion. You can see the plaque here is the intima is continuous, but there is some erosions that led to formation of a thrombus. In this case, you can see that the lumen is not continuous and there is a plaque rupture and a red thrombus inside the lumen. An important point to differentiate between stable coronary artery disease and acute coronary syndrome is that the plaque does not have to reach 70% or more stenosis to be complicated by rupture or erosion. And a small plaque, maybe 20%, 30% stenosis can rupture or erodes and cause acute coronary syndrome. So to develop stable coronary artery disease, you need a stable plaque that causes narrowing 70% or more to cause symptoms. Whereas you might have a small plaque, 30% or less, that ruptures or erodes and causes thrombosis and acute coronary syndrome. This is an OCT illustration from a living patient. You can appreciate this is the intima, this is the intima, and here the intima is not continuous. This was a lipids, and this was the thin cap, and the thin cap ruptured. And we can see this is a thrombus. And this is a thrombus inside the coronary artery. This is plaque rupture. In summary, both stable coronary artery disease and acute coronary syndrome start with atherosclerosis that causes an atherosclerotic plaque. In stable coronary artery disease, the plaque is of the stable type, mostly fibrous or calcific. When it reaches a 70% diameter stenosis or more, the patient starts to develop a chest pain that occur with emotional or physical exertion. In acute coronary syndrome, even a small plaque might be 30%. However, it is vulnerable and unstable, is complicated by plaque erosion or plaque rupture, causing thrombosis and acute obstruction of the flow in the coronary arteries that leads to chest pain that might occur at rest without exertion, lasting for more than 30 minutes, and we will talk about this in details in the lecture of the acute coronary syndrome. Thank you for your listening. For further questions or requesting the PowerPoint slides, if you need the PowerPoint slides of any lecture, please send your WhatsApp number on this email and I will send the lecture back to you. And this is a clinical book of manual of clinical examination that is prepared by our dear professor, Dr. Hisham Salah, in the cardiology department, and me and some of our colleagues. It is very good to help you in studying clinical examination in general. Thank you and have a good day.